Name is Najol. I'm one of the second-year internal medicine residents from Advent Health, Orlando. Today, I'd like to share a case with you, a case of transient hyperthyroidism of hyperemesis gravidarum, which was successfully managed with plasmapheresis. We know that appropriate treatment of transient gestational hyperthyroidism is very important, and if left untreated, is associated with increased risks of adverse maternal, fetal, and neonatal complications. Therapeutic options are limited, and PTU combined with beta blocker is the main available treatment during the first trimester based on current guidelines. We encountered a difficult case with severe refractory hyperemesis gravidarum due to thyrotoxicosis. This is a 31-year-old female who presented with progressively worsening nausea and vomiting in the past 2 weeks. The pregnancy was confirmed with ultrasound of the pelvis, which was consistent with a single living intrauterine gestation of 8 weeks and 5 days. Medical history includes hyperthyroidism in both of her prior pregnancies, with the second one being treated with PTU. Physical exam was benign. There was no thyromegaly, no ophthalmopathy, no tremor. Vital signs with borderline tachycardia otherwise were within normal limits. Labs with elevated beta HCG, free T4, decreased TSH, normal CBC, liver and renal function, mild hyponatremia and hypokalemia likely due to poor oral intake and vomiting. Unfortunately, the patient failed supportive and symptomatic management, including IV hydration, multiple antiemetics, and steroids. Her symptoms continued to get worse, and she was not able to tolerate any oral intake, including PTU. And during the treatment course, elevated liver enzymes were noted. We can see from the figure that the liver enzymes were elevated and continued to trend up with maximum ALT more than 600 and AST around 200 on day 10, day 11. Liver injury panel were negative. At this point, we were in a treatment dilemma. Patient symptoms continued to get worse, and she developed acute liver injury likely due to uncontrolled hyperthyroidism. But we exhausted all the conservative management with no improvement of clinical condition. So we decided to try plasmapheresis since the benefits at this point outweigh the risks. The patient had 3 sessions of plasmapheresis every other day. So after each session, we can see a significant drop of both liver enzymes and FT4. After 3 sessions, the FT4 and liver enzymes were close to the upper limits of normal range. Clinically, the patient's symptoms were significantly improved. PTU was reintroduced and patient tolerated well. During the follow-up visit, which was 2 weeks after hospitalization, patient had intermittent mild nausea and vomiting, which was managed by oral antiemetics. She was on PTU with a stable liver and thyroid function. Application of plasmapheresis in thyrotoxicosis in pregnancy is rare based on literature review. Back to 2000, there are only 3 case reports on PubMed, with 2 of them were employed in molar pregnancy for rapid hormone control and preoperative preparation when fetal safety was not in consideration. Based on our understanding, the concern of plasmapheresis in pregnancy is more from the uncertainty of safety in this special population, since there is very little evidence available. We successfully implemented plasmapheresis in a case of thyrotoxicosis in pregnancy, and we think it is a reasonable alternative therapeutic option in pregnancy in the management of transient hyperthyroidism who failed or was not able to tolerate or have contradictions to antithyroid medications. Our case provided new evidence for plasmapheresis in treatment of thyrotoxicosis in pregnancy. Hopefully, with more data and cases available in the future, we can establish a pregnancy-specific protocol with the consideration of pathophysiological changes in pregnancy and promote the efficacy and safety of plasmapheresis in pregnancy. It's my pleasure to share this great case with you, and thank you so much for listening.